a dreaded topic
Yes.
if it's coming in the exam. So when Gunadhar asked me what we will present, I thought I'll take this because I've been doing this with our NABH team for the last 6-7 years. So I thought I'll take up this topic.
Yeah. So, Dr. Indranil, so before we start, just a small introduction. All of our moderators are here. And
Okay.
Swapnil, can you start with, or we should directly go ahead? Swapnil, if you are there.
Yes, sir. I'm there, sir.
Yes.
So,
Just start,
I
no,
welcome.
we're already late. Forget the introduction. Yeah.
No
I think
problem,
just
sir.
2 minutes. 2 minutes. We'll start.
Good evening, everyone, all my seniors and all my colleagues. So, today is 45th educational series on platform of Apollo Mumbai Critical Care Learning Network. And today's topic is quality indicators in ICU. I welcome our speaker and moderator. I introduce first all moderators. The first is Dr. Gunadhar Padi, who is senior consultant and intensivist physician at Apollo Hospitals, Navi Mumbai. I welcome Dr. Akhilesh sir, who is also intensivist physician in critical care department. I welcome Dr. Swadip Sen. He is also senior consultant and physician at Apollo Hospitals, Navi Mumbai Critical Care Department. I request Dr. Gunadhar sir to introduce first our speaker, Dr. Indranil Raut. And I hand over from here to Dr. Gunadhar. It's just a bit fast today because we are already late, sir.
Yeah, I will. So basically, today we have a very good eminent speaker, Dr. Indranil. So he is one of the NABH assessors. So that is the reason we are very much interested the presentation like ICU quality indicator, which is one of the benchmarks. I think this is how we compare the different ICUs, and let's hear from him what are the best indicators and how we can improve the quality of our standard of our ICU. Yes, Dr. Indranil. So he's physician come critical care consultant, senior consultant, Jaslok Hospital, Mumbai. And we all welcome him to our platform. So Dr. Indranil, please, let's start.
Good evening. Good evening. Thank you for giving me this topic, Gunadhar. So ICU quality indicators, all of us, I think, are aware of this terminology because of JCA or NABH accreditation. And I think most of the corporate hospitals in Mumbai are doing these indicators. So let us just go through the how the quality care has evolved over a period of time. One of the first documented evidence of quality control was, by Florence Nightingale. She actually studied mortality rates of military hospital during the Crimean War. That was as early as the second half of 19th century. And then in 1912, there was this Eris Coleman who developed a method that allowed to study the outcomes of surgical methods to be measured and classified. Then in 1918, the American College of Surgeons, they came up with this defined minimum standards that the hospital needs to follow. And that led to the foundation of accreditation as early as 1918 in the US. In 1951, there was this creation of Joint Commission of Accreditation, or what we call the JCH. I think many hospitals in Mumbai are already accredited to the JCH as well. Next slide, please. Yeah, so in 1950, the medical audit terminology was coined, and that the audit started by someone called Paul Lembach. And in 1965-66, there was an establishment of Medicare and Medicaid federal programs, and they were helpful for the senior citizen. But what the US meta criteria was that this will be applicable only to the hospitals who will undergo JC accreditation. And you see similarly also now that many Mediclaim companies are telling that they will give Mediclaim only if the patient is admitted in the NABH or an accredited institute. So 1970, Williamson introduced a new methodology based on the ABNA, what we call as an achievable benefit not achieved. So you're studying the standards, diagnosis as well as outcome measures, and comparing whether the achievable or the desired outcomes were achieved or not. Then came the famous Donabedian. Sorry, can you go to the previous slide? Yeah. So he helped to rethink the concept of quality in healthcare, and he classified the method of quality assessment into structure, process, and outcome in as early as 1966. So the Joint Commission of Accreditation of Hospital then had a system of all centers applying for accreditation to have integrated quality plans for the entire center. And there was a lot of opposition, obviously, for this, but then that led to an establishment of a standard that implemented the indicator measurement system all over US. Finally, in 1990s, the JCHO developed a system of outcome indicators integrated into the accreditation system. So how do you, what is the methodology for the evaluation and improvement of the quality? The two basic approaches. We have to see the room for improvement. So identify the problem, analyze what has gone wrong, and then propose the improvement. This is based on W. Edwards Deming's cycle of evaluation and improvement, which is called the PDSA: plan, do, check, and act. And then the monitoring system. So detect problem, we have to detect the problems and periodically evaluate the performance. Then the fundamental unit, which how will we do that is by the indicators. So this diagrammatic thing says the same thing. The monitoring system, you have to detect and prioritize, analyze the causes, then define the criteria by which you want to do so. Design of assessment studies and analysis of action for improvement. Implement, reassess. If your desired outcomes are still not there, you again analyze what has gone wrong and then carry on that. So monitoring system periodically measure and evaluate relevant aspects of the care by means of quality indicators, which are the basic unit of a monitoring system. And what they require is first, like you have to define, first be defined by the process of dimensioning. And what are the dimensioning aspects of dimensioning? Establishing the principal care areas, elaborating that the indicators will enable the outcome of the healthcare process to be measured. So which area you want to assess, like suppose ICU or a burn unit or something else, like you want to assess the admission counter. So monitoring to identify the problems, situations that can potentially improve or deviations from the standard, and what are the indicators they serve to call for attention to these problems and sound an alarm that something is going wrong. We need to check ourselves. So it is essential that that the indicator reflects reality and useful, because they are the measurements of the quality. So you have to see that they're useful and as well as real as possible, and not just made for the sake of it. So the three properties of indicator, which is will be if a good indicator will be validity. So you have to see whether it is actually fulfilling the aim and identifying the situations and the quality can be improved. Means whether the indicator we are monitoring will actually help us in modifying what is going wrong, or whether it really needs to be monitored. So that is the validity. Then sensitivity, when it detects all cases in which a real situation or problem with quality of care occurs. And specificity only detects those cases in which there are problems related to the quality of care. Like means you're looking, when you're looking at WAP, and then you're looking whether the WAP bundles are followed or not. So that becomes specific. So what are the steps in designing the monitoring system? We have first to define the process, then identify the most important aspects. Then you design your indicators and establish the standards. So you have to collect the data, tabulate the data, and then what do you compare with? There may be international or national standards set. You compare your data with that and see whether you're achieving those benchmarks. If you're achieving the benchmarks, fine. It's a good thing. But if you're not, then you have to identify where are we lacking, where are we going wrong, and then improvise on that and make steps to improvise on that. So, suppose, for example, if you are having a hand hygiene audit and you're not matching the hand hygiene audit is done in each step of care of hand washing. And you identify that in the fifth process, everybody is going wrong. Like that means after touching the patient or the patient belongings, you are not washing your hands. Then you need to see and find out how we can correct that. So the indicators will be discussed on this criteria. This dimension, that is the most important aspect of care assessed by the indicator. Justification, why you need that indicator. Then you need to have a formula. Like what is the indicator? Suppose it's a mortality rate. So what is the formula? How will you calculate? Because it has to be standardized, right? You cannot have different mortality rates in different ICUs. So explanation of the terms, you have to define, or what is say, simplify the terms for the people who are utilizing this. Then you have to identify the population, whether you are doing the mortality rate in the surgical ICU, in the medical ICU, or any other I would say clinical area. What is the source of the data? It's human, or it's the HIS system which is obtaining the data for you. So that is the source of data. And then whether the standardization. So you're analyzing your data after at the end of maybe in the time frame, maybe a month or yearly or 6 monthly, and then you're comparing your data or the analysis with the international or national benchmarks. Next slide. So there is some, you can have some criteria to choose which indicators to employ. So there should be you should know the basic aspects of care. So to suppose central bloodstream infection, what steps things can go wrong, and that's how you can form a bundle and then see whether the bundle is being followed. Possibility of risk, and then existence of valid and reliable sources of information. So who is going to collect the data? I mean, who is going to monitor? Suppose we have in our hospital, we had started a form where when we are putting the lines in the ICU, somebody will come and analyze this thing. I cannot say I've done all the procedures properly. So then we had that ID nurse who would come and watch us while we're doing the procedure. We had a pamphlet where she would tick a checklist, whether everything is done. In charge in that ICU to analyze while we were doing the line. So that's how the source of information is. But for many other things, many of the hospitals easier for them to get the information online, and maybe easy for assessment also. Next slide. So type of indicators, we refer to the classification according to the focus of evaluation. So they may be the structure that they measure. So what will be the structural the indicators for structural aspects to technological, organizational, or human resources necessary for care? For example, technology means suppose what do you say? If you have your monitor which is shut down, or a CT scan which is shut down, so how much was the downtime? That would be the technological thing. Or if you say human resources, I mean, what is the attrition rate? Or that would come into human resources. Processes that evaluate the way in which the care is delivered with the resources available. So whether you are following a protocolized approach. So if patient comes with septic shock, is the EGTT being followed, or the antibiotic has to be given, cultures have to be sent antibiotic. So you're assessing in the EMS itself whether the culture is being sent and the antibiotic is given within the stipulated hour. So if you have a set protocol, whether the protocols are being implied on. So that would be the indicators which would help in the processes. The outcomes measure the consequences of the healthcare processes expressed in terms of complication, mortality, opportunities missed, failed circuits, etc., which would again example is the mortality rate, which would show that your processes are good. Or if you're ventilated associated pneumonia, so how good your bundles are being implied to prevent the VAP would be indicated by your VAP rate. So these are a lot of clinical suggestion. This is, I think, coming from the ISCM. There was one Spanish society which gave about 40-50 parameters when it was more clinical, whether your acute MI was thrombolized within the window period, whether a stroke was thrombolized within the window period. So that kind of a thing. Each clinical aspect or the process was studied. This is suggested by the ISCM, like mortality would be accrued or severity adjusted disease-based hospital. So 3 different types of mortality we can. Then morbidity, incidence of accidental intubation, accidental extubation, delining, pneumothorax while putting a line, and all nosocomial infections would fall into this. Next slide. Cost effectivity. So what is a patient and ICU day cost to the institution? Then what was manpower cost? So this is all more of the admin or this issues monitored here. Safety is one of the most important in prevention of complications in the hospital. So identifying adverse events in the hospital, like medication errors and reporting. Okay, that would be falling in the safety. Then blood component therapy, whether any reactions to the blood or whether appropriate components are being given or not. So even whether we are giving platelets, the right indication will also fall into this. Whether we are using whole blood or packed cell would be included in this. Then what about broad spectrum antibiotic? Like what about your antibiotic program? Whether we are de-escalating, early de-escalation is going on or not. So all this would come into the safety of the patient. Next slide, please. Of course, needle stick injury and any injury during work would come into the safety. Manpower, of course, whether you're having appraisals are given on time, the staff is satisfied or not, would come in that. Then resource utilization, what is the length of stay in the ICU, average ventilator days, then equipment utilization, downtime, as I mentioned. Next slide, please. Okay, and then finally the customer satisfaction. So one is the our patient and relative, whether they're satisfied, whether they've been talked to, so whether their complaints have been solved. Okay, so we have to take the feedbacks. So that also becomes an important indicator. Right, next slide. Okay, so quality of care in medical practices in general and critical care is the responsibility of care providers. So clinicians involved are morally and ethically bound to enhance the quality of care given in our units. And why do we require this quality management? Because we have to judge the appropriateness and effectiveness of our therapies in critical care. And thus the quality indicators will help in achieving the following objectives: the quality of the service offered. So whatever you're giving, whether it is appropriate and it is helping the patient or it is causing harm to the patient. Results of intervention and treatment. Undesirable outcomes. That means our complications. You're putting a central and you caused a hemothorax or a pneumothorax. So undesirable outcomes. And other managerial and treatment related processes. So it is becoming nowadays mandatory for the institution to monitor the quality indicators, parameters to compare the performance level with local as well as national and international bench standards. And the Indian Society of Critical Care in its executive body meeting in 2008 took the initiative to identify some quality indicators for the ICU. So let's go through them one by one. The possible units for benchmarking were different ICUs, like medical ICU, neurological ICU, neurosurgical ICU, and the benchmarks would be different for each ICU. Next slide, please. Let's go to the next slide. Yeah, so various parameters for the quality assurance in ICU in which these indicators are studied are mortality. So mortality would mean the SMR. We'll come to each one. Then the morbidity parameters. So an iatrogenic pneumothorax, incidence of acute renal failure in the ICU, in the non-coronary ICU. Then decubitus ulcers or a bed sore. The operational process, length of stay, compliance to protocols, and readmission to the ICU. Error in patient safety. So patients fall rate, medication error, adverse events, sentinel events, needle stick injury, and reintubation rates. And infection control would be the three famous VAP, UTI, CLABSI, and even an SSI, which is not mentioned here. Human resource, overall employee satisfaction, and customer focus, patient satisfaction. So these are the 7 headings in which the ISSM made this quality indicators. So let's first look at the mortality, that is a standardized mortality rate. So we all would say, okay, mortality rate is the number of deaths in the ICU and the number of patients we treated. But it is not as simple as that, because that would vary from patient to patient depending on the severity of their illness. And suppose you have a terminally ill patient. So so they are not necessarily the indicators of the performance, even if those are referred to. So what the SMR does allows comparison of actual performance of the institution with the predicted performance based on the average mortality as expressed by the national and international data. So what is the rationality of this is that the risk of death varies with, as I mentioned, severity of age, disease, and comorbid condition. And crude mortality is therefore not a sensitive indicator. So what they do is they calculate the predictive mortality from models such as the Apache, SAPS, and other severity scores. And then they compare it with the actual mortality. So what is an SMR? Can I have the next slide? So what is the formula for calculation of a standardized mortality rate? So risk adjusted mortality equal to observed rate upon risk adjusted expected rate. So observed rate is what is actual death in the ICU. So if you have 3 deaths in this month, okay, and then you have a process where you are capturing using some score. It may be any score where you are capturing the scores, and then based on that you're predicting, okay, this is going to be this was the expected mortality for that ICU. So if the ratio is equal to 1 or 100, that means you're falling in good average. I mean, it's a good care, supposed to be good care. If your ratio is more than 100, at which means the hospital's mortality rate is higher than the expected average mortality rate. And if it is less than 100, that means your actual rate is less than the expected average. So higher SMR, however, does not necessarily mean that the hospital is unsafe, as this is a snapshot method, and simultaneous assessment of other quality indicators must be done. So I'll give an example. Recently, we had a young lady who came up with multi-organ failure and jaundice and renal failure and all those things, and hepatosplenomegaly. We were strongly thinking of leptospira, but initial leptospira was negative. And in a space of 48 to 72 hours, she died. So when I was evaluating the SMR for this month, I realized that her Apache score was hardly I think 14 or 16, which makes the mortality to less than 50%. The predicted mortality for Apache 2. So we follow the Apache 2 score here for this predicted mortality. So, looking at her, she was so sick. But this parameters for the Apache 2 would have specific, like, the PO2 FiO2, which was not bad initially. The creatinine was not, it was, I think, 1.6 or 2 when she came in. So by the Apache scoring, or the scoring was only 1 probably. So that way her score was not going high, but she died. So, were we wrong? Did we manage her well? I don't know. But, retrospectively, after her death, we got the history from the relatives that she had been on an alcohol binge for 3 months. So such things may be missed, and not always all these indicators would mean that, what you're doing is wrong or what you're doing is perfectly right. You have to use it with your precision. Next slide. So this is quite clear, heterogenic pneumothorax related to procedure. So it is associated with a lot of mortality and morbidity, you would agree. And especially in the COVID scenario, if you all remember, pneumothorax was almost catastrophic whenever it occurred. So it is quite simple. The formula, that number of pneumothorax upon the number of cases into 1,000. And benchmark. So benchmark is 0.83 per 1,000 cases. Next slide. So incidence of acute renal failure in a non-coronary ICU unit. So we will have to first define what you will be defining by the acute renal failure and non-coronary. So wherever the renal, any acute renal failure requiring renal replacement therapy, or when the urine output is less than 200 ml per hour, or when the azotemia or the blood urea is more than 84 during the patient's ICU stay. Now here, why this has been taken up is because if there is a renal failure, the mortality increases to almost 60%. Whether the renal replacement therapy has been initiated or not. And that's why this parameter has been included as an indicator. And even a modest increase in creatinine level from 0.3 to 0.4 increases the risk of death by 70%. So what is the formula for this? Number of patients who developed severe renal failure upon number of patients managed in the ICU into 100. Now here we will be excluding the chronic renal failure patients. You're just taking the acute renal failure here. Okay, now this is an age-old. I mean, I remember in Jaslok, probably about 8 to 10 years back, we were monitoring only this as the quality indicator, and our quality department, there was one lady who used to come in once a week and just ask for bed sore. That's it. From there on, now we have come a long way as far as, and there's, I think, a lot of more scope to go and go further. So just coming back to the decubitus ulcer, everybody knows what is decubitus ulcer is, and it does imply poor care. If the patient is coming without a bed sore and in the ICU, we are giving a bed sore, and the implications and morbidity with associated. Suppose 1 and 2 is fine, but if the patient gets this grade 3 and a grade 4 bed sore, where you can have a lot of increase in the hospital stay, and the cost to the patient is terrible if patient gets a stage 3 bed sore. So it is one of the premier most morbidity indicator, or the care reflects the care process in the ICU. How will you count it? Number of pressure ulcers, some of the number of cases into 1,000. So with this monitoring and quality indicators and all, definitely over the years, I mean, in one center only for last almost 17 years in one ICU. So I've seen a lot of progress. When we started monitoring these indicators, especially this bed sore, we are almost close to less than 1% every time when we analyze for our NABH. So definitely, I think monitoring and having a dashboard of these indicators does help and does motivate the staff to do better. Okay, now let's go to the operational parameters. Length of stay. Please get back to the slide. Length of stay. So total hours and days patient managed in the unit with midnight bed occupancy is more accurate. So what is the formula? So length of stay means if the patient stays longer than what he needs to stay, which means either our processes are not good or we are being too precautious, and it also means probably we are not confident that our floor facility is good. So that's why our length of stay may be high. At the same time, if our length of stay is short, and our readmission rate is high, that means you're not taking your decisions properly of shifting the patient out. So how do you calculate that? So total occupied bed days upon number of patients in a given frame of time. It may be over a week or a month or a year. So length of stay is often used for is for different patients. The benchmarks are different. Like a surgical patient will have different, a CABG patient will have different LOS, and a medical patient will have a higher LOS. So next is the compliance to protocol. So what I was coming to was about the length of stay was many times the length of stay in open ICU and a closed ICU becomes difficult because the sometimes the consultant would like to shift the patient early, and the intensivist knows that the patient is not good enough to be shifted, and then I think you have to be firm, because when the patient comes back readmission within 48 hours, again it's a indicator of the quality of care in the ICU, and then the ICU team is sure that, oh, you people have not shifted. So we should have discharge and admission protocols, and they also they can be modified from time to time, and we should assess whether we are really following the protocol. And even if it's an open ICU, I think if there is a senior intensivist who talks to the consultant and says, okay, I don't think it's fit to be shifted out, then most of them would listen, and this complication of readmission would be prevented. Okay, so just because you're talking of the protocol, compliance to protocol, just go back to the earlier slide, Gunadhar. Yeah, so compliance to protocol is another indicator. So if you have protocol set for the ICU, then you need to, why do you actually need to do this? So compliance to protocol, guidelines and treatment bundles are expected to improve patient care. So compliance of protocol could be absolute non-compliance, partial compliance. So what is the formula? Number of times followed upon number of times expected to follow. So the easiest example would be the hand hygiene protocols, where at each step 1, 2, 3, 4, 5 we analyze. Our ID nurses do a wonderful job, and in every infection control committee meeting they present a wonderful graphical presentation, and many times it causes an embarrassment because it's usually the doctors who are in the worst category many times that the hand wash is not done. So so this compliance would, suppose your VAP rate or yours is high or your CRBC rate is high, then you very well know, if you go back to your hand hygiene and see that the hand hygiene compliance is poor, why your infections are occurring more. So that's why the compliance to protocols also needed to be audited. Next slide. So I just spoke of this with the length of stay. So readmission rate is an important indicator. Readmission to ICU is monitored whether it is occurring within 24 hours. So a zero admission rate reflects, it would also mean, suppose you have a zero readmission rate in 6 months. It also means that maybe you're overprotective and you're not sending the patients and they're completely all right. But also if your readmission rate is high, that means one, that it could mean that you are a bit premature in sending the patient out, or your ward care is not good enough. And that's why the patients are coming back within 24 hours. Error and patient safety profile. So patient safety is an important component in all the hospitals, and even when the NABH assessors come, I've seen that they're more hell-bent on patient safety and other things. So one of the indicators of patient safety is patient's fall rate. So patient fall in the ward I can still understand, but in the ICU is really embarrassing for the unit heads and the ICU heads, because if that really reflects a poor care in the ICU, the patients are falling down from the bed. So untoward events which result in the patient coming to rest unintentionally on the ground or on the lower surface. It could be accidental, anticipated or unanticipated physiological. So how do you measure? Fall rate equal to number of falls upon number of bed days into 1,000. Okay, now medication errors. So medication error is one of the commonest errors which occur not only in the ICU but in the wards. Medication error at all levels. Firstly, in your prescription, whatever we write, then indenting error can occur because you wrote something properly, but the sister has indented the wrong. Secondly, administration. Thirdly, administration. So you've written correctly, sister has indented the correct drug, but while administering, she has given it wrongly. So administration errors can be like, she's given at the wrong timing, she's diluted wrongly, like the amphotericin B was not diluted in 5% dextrose, or the quadron was not diluted in 5% dextrose. Nowadays, with our sepsis and all, we like to give antibiotics or prolonged infusion. The sister gave it as a bolus. So all these things would mount to the administration errors. Now, if you just see that medication error occurred at a mean rate of 19% in hospital. So, but a lot of medication errors go unreported because the fear of penalty. So what any hospital or unit should always encourage reporting and assure that the neither the person responsible for the error should not be punished for the same. At the same time, the approach should be as a system we need to change, not the person, because the person may be doing a medication error because there is a fault in the system. Now, suppose the sister is not given the antibiotic for 3 hours. Maybe there was a there was a problem while she was indenting the drug. Then maybe the pharmacy was not having the ward boy to send the drug to the ICU. So it's not always a fault of the sister. And that's why the system, whenever we identify errors, it should not be individualized penalty. It should be a system change, and we need to identify the flaws in the system. Maybe the sister was overworked. She was doing a double duty, and that's why she made an error. Maybe the doctor on duty was doing a 24-hour shift, and he made an error in the judgment, or he wrote a wrong drug instead of writing the correct spelling or the. So medication error rate is the number of errors and the number of bed days into 1,000. So if we even if we exclude, so nowadays for the NABH purpose, they're even monitoring whether we have written in capital, whether we have written per oral, whether we've written IV. Then they don't like the trade name. They want us to write the generic name, like Merofic or Meronem will not do. You have to write Meropenem. So if that way, if you go, the medication error are lots. But if we exclude those, then also a lot of errors are going unnoticed. Who is looking at interactions? So what is recommended is that we should have not only an ICU clinical pharmacologist to help us identify the drug errors and all these things. A simple thing as the omeprazole, which cannot be crushed and given through the RT, was pointed out to us when we started having an ICU pharmacist. We were crushing, when an RT patient, we were crushing the omeprazole and giving it, but the purpose is not solved. So we have to give a omeprazole sachet and not a omeprazole tablet. So medication errors, I think any ICU unit should be closely monitoring the medication errors. Next slide. Adverse events. So common ICU errors are related to treatment, procedure, ordering. So adverse event would cause, it would mean a medication error. Even what do you say? Suppose you are giving a hot water bag to a patient and patient gets a burn, it's an adverse event. If you're giving quadron through the peripheral vein and you get a bad thrombophlebitis, then it becomes an adverse event. Okay, and the worst adverse event is a sentinel event, where it might cause severe or grievous harm to the patient or even death to the patient. And near misses, where a serious harm could have occurred, but you found it out in time and you stopped it from occurring. So usually near miss is at the tip of the iceberg, and if a lot of errors are being underreported, so you should always, when their near miss proportion is high, that means something is going wrong. So how do you capture the adverse events? Adverse events upon error rate, that is the number of error upon the number of bed days into 1,000. Okay, needle-stick injury rate is from the safety perspective of the staff, and I think a lot of us now are using those. When we're putting IV cannulas, we are using those where once you are out, it'll form a hub, and we are not supposed to cap, and all those things all of us know. So because needle-stick injuries can cause deadly diseases like HCV and HIV and HBsAg, you have to monitor, as it's an important indicator, and the incidence per 1,000 venipunctures has to be measured. Okay, coming to the reintubation rate. So again, it applies to the ICU strongly. So reintubation within 48 hours of extubation is an important indicator of morbidity or even mortality sometimes. So it can be accidental, or it can be what do you say, anticipate or elective, in the sense that we have asked for an extubation and probably our judgment went wrong or something new occurred and the patient had to be reintubated. So so the number of reintubation upon the number of patients extubated into 100 is the reintubation rate. So often we are scrutinized. I gone through many NABHs, and while we present the data, suddenly that NABH assessor will ask you, "Oh, ye month mein zyada tha." Now we wouldn't remember that in, suppose your NABH assessment is in December, and then January, why that patient got re-intubated, why your re-intubations were 3, you never know. Sometimes you have given a trial of extubation. Suppose there is a COPD patient and borderline. So you would probably give a trial of extubation to such patients, on trial to BiPAP and all those things. So there sometimes things are acceptable. But if a routine surgical patient is there, or and you extubate and you have to re-intubate, then there's bad. Accidental extubations, like patient pulls out the ET tube and that warrants a re-intubation. Or if your endotracheal tube gets blocked by secretions, I think those are not, or your tube slips out accidentally and then you have to re-intubate. I think those are not acceptable ones. So the indicators of infection control, I think all of us know that, and all of us are doing it. So one is the ventilator-associated pneumonia. In US, I think people have started suing the hospital for getting VAP. And that's how the VAP definitions have changed. And you know that about VAT and ventilator-associated tracheobronchitis, and then finally VAP. And a lot of things, and there are surveillance definitions which are different and actual VAP definitions which are different. So it's a huge complicated definition thing which you can see on the CDC or the IDSA website. So formula for calculation is patients with VAP you identify upon the per 1,000 days of mechanical ventilation. Or it's actually yeah, so these are the signs, and all of us know that, so I don't want to go into detail of that. But surveillance, remember that the surveillance definition of VAP are different, a little different from the clinical definitions. To the next slide. Yeah. So formula, okay, now coming to the CRBSI. So another important aspect of the infection control in the ICU. Its description is bloodstream infection rate, number of central line related bloodstream infection per 1,000 central line days. So let's, this is quite old. This guideline was in 2009. So at that time, imagine there was 26,250 deaths per year in the United States, which is a huge amount. So we have to, and I think after that, lot of bundle and lot of improvement in the rates are there as far as the central line infections are concerned. Again, formulas have kept changing for definition of CRBSI. And again, I don't know whether they are again related to the dynamics of litigations for hospital-acquired infections. Some of the criteria is relaxed. Like suppose you already have an infection before coming to the hospital, not CRBSI, but any other, and then you get a line related to CRBSI, or you already have an infection in the body in some other place, and then you grow something from the center line, it's not considered a CRBSI. So all those things have a lot of nitty-gritties in the formulas are there, but the formula is simple. It's identifying the infection which has become difficult. So means proving that this was a CRBSI, because the formula is simple: number of central line associated bloodstream infections upon number of central line days into 1,000. There are a lot of international benchmarks which you always compare, and then our management says, oh, the CRBSI rate in your ICU is very high, you people are not taking care. But at the same time, many of the international guidelines are based on optimum care. So the nursing patient ratio is excellent there, and we always should not get depressed when we see our ratios, our indicators are not matching to international standards, because we should compare it with the way we are staffed, the way we function. So if you're not able to give a 1:1 for a sick patient, then how do you expect quality care? So even though the ISSM is not included, that is also nurse to patient ratio, working hours in the ICU. Those are also important indicators, I think, which in the long run will be included as a predominant indicators for care in the ICU. The last, yeah, so UTIs, yeah, so urinary catheter related infections, number of UTIs upon number of catheter days 1,000. In our hospital, we have bundles laid down for CRBCI, for VAP and UTI or 40 all over the hospital, and our ID nurses identify this rates, and they keep a track of especially the catheter bundles even on the floor. Each and every catheterized patient is assessed, nursing care is assessed whether they're giving they're giving the catheter pair in each shift. And so that means we are monitoring two things. We're not only monitoring the rates, we're also monitoring the bundle care. And in fact, in our ICU chart, we have the WAP bundle as well as the CRBSA bundle in our ICU chart itself, so making things easier for them. Okay, so as compared to human resource, the indicators such as the staff satisfaction is also important. Whether you have staff attrition rate, suppose your staff is repeatedly leaving for whatever reasons, which means that you're going to have new staff to train, and they may not be as for till the time they're trained, their functioning may not be as optimum. They may not follow all the quality guidelines. So attrition rate is an important quality indicator in the HR area. Next slide. So overall employee satisfaction. So satisfaction level of staff working in the hospital or the unit, and if the staff is satisfied, he's going to give you a better care to the patients and better outcomes to the hospital. So, and if the satisfaction is high, you retain more staff. So formula for calculation on a 1 to 5 point scale, where 1 represents lowest satisfaction and 5 indicates the highest possible satisfaction. Customer focus. So ultimately, whatever care we are giving, are the patient and their relatives happy with the care? And that's how one is our clinical indicators, and one is this. So whatever you've done, all patients are not going to come and die and are not going to be critically ill. Some of them are just going to come post-op for one day in the observer. And if the relative is not satisfied with the care given or the information given, sometimes patient, even the cancer patient, he's so many ill and he's going to die. But if the family is not happy the way we are giving the end of life care, the way we are taking care of the patient, then they're never going to rate your hospital properly, and they're not going to come again to your hospital. So customer satisfaction is an important part, and that is also becoming an indicator for the care in the ICU. So formula for calculation, you have to do surveys. Each hospital has even consoles now to give survey. In our ICU, there's a PRO who every patient, when he goes out of the ICU, they give a feedback form, and that's how they evaluate. And again, as many times they give a score out of 1 on 10, and then various aspects. Doctor ne baat kiya ki nahi, have you been attended by the maushi or the ward boy, and all those things are given, and then the ratings are done. Food forms an important part of the feedback. So customer focus or patient satisfaction and relative satisfaction is one more quality indicator. So what are the limitations and concerns with our indicators? So a lot of stress has been given on mortality, morbidity, infection control, and so acceptability and utility of these parameters in this Indian scenario will have to be assessed. I guess this whole article was in 2008, and a lot of hospitals have evolved, and I think everybody, almost all the good corporate hospitals, are incorporating all these clinical indicators on the day-to-day basis. As I told you earlier, diagnosis of AP is controversial. The clinical and as I told you, the surveillance definitions are different or slightly different. Okay, then somehow in our country, compliance to protocols have not been even more importance. In fact, many hospitals just have protocols for the sake of it, but the protocols are not being followed. Sometimes protocols may be difficult to follow in an open ICU because, for example, I'll tell you, one of the hospitals, 5 different cardiac surgeons had a different antibiotic to give as a prophylactic antibiotic before the surgery. So how do you deal with that? Then some institutions may have reservations in sharing the database due to lack of logistic support. Many institutions may find it difficulty in generating regular and meaningful data. So if you're not adequately staffed, you require somebody to monitor all this. Like suppose your quality department doesn't have anybody, just one person, then how are they going to capture data? You can't expect your sisters to do everything. Next slide. So basically, we also need to have our national data. We are just always comparing with international data. Like as far as I remember, for the NABH, we're just always comparing with the international benchmarks. So when we register our data, each hospital, and then send it to some national registry like an NABH, I think we'll have our own data, and then we'll have a benchmarks for us to compare at our level and then compare with international levels. Okay. So just to conclude, quality indicators act as a yardstick to measure the level of care afforded in a unit over a period of time. Variation in care in the unit and among different units with similar case mix can also be done if indicators are compared on regular basis. Quality of care in ICU depends on complex interaction between patient, machine, and care providers. Process-driven and protocol-based management should eliminate the ambiguity and ensure better outcome. Such approach is not possible unless care is provided, is quantified, and gap between current level and desired level assessed, followed by improvement initiatives taken to bridge the gap. Selection of indicators and monitoring the same, therefore, should be considered as the most vital and challenging task to bring continuous improvement in the performance level of the unit. Thank you.
Thank you, Dr. Indranil. So can I stop the sharing slides?
Yeah.
Okay.
There's one more slide I want to share. Just go ahead.
Okay.
Yeah. So this is slide. So the objective of having standards is to raise them. I feel this was an important, very nice sentence by this gentleman. Thank you.
Yeah, I fully agree with it. Basically, the main purpose of the quality is to measure it and to improve the standards. So there is a famous quote like, if you don't measure something, you cannot improve the standards.
Yeah.
So as you rightly told, the measurement is very important. For measurement, we should have sufficient, adequate, the manpower,
Yeah.
the proper statistician, and the quality team who should lead the organization. So my only one or two questions to you, like you have attended a lot of this NABH assessment in many of the hospitals, in your hospital also.
Yeah.
You're working almost for last 17 years in Jaslok. So what are the minimum standards and criteria the hospital has to follow? And what are the minimum standards the intensive care unit has to follow for the NABH benchmarking? And apart from NABH, there are other lot of international accreditation body like JCI, and those also, like our hospital is JCI accredited. So what are the things one should be very much aware about, like our junior intensivist?
So I think our hospital yet is not applied for the JCI, but JCI are more stringent than the NABH. But the only thing, sadly, many times we do keep a tab of this monitor, this indicators which are presented in meetings. They're well taken care of. But many times, lot of things are, I think they are done only when the NABH is about to come. So that is what is the sad part. Then I find that the reporting is very bad. I mean, very, very under-reporting, especially medication errors. So at least I think we cannot take care of the ward, but in the ICU, we should make a system where fearlessly the medication errors are being reported so that we can improvise on them. In drug interactions is quite neglected in the ICU. So that I think is a predominant thing. Which, as far as the infection control parameters, of course, it is utmost. And I think at least in our hospital, the bundles are being followed and regular assessment is done. And I expect, I mean, I'm sure all the JC accredited hospitals are doing the same. But as I told you that many hospitals, they buck up only when the accreditation is due, unless 3 months things are done. At least in our hospital, I have not seen the data, at least which is going from our ICU or from the infection control team being manipulated for the sake of NABH. I don't know about the other data, but at least from these areas, I have not seen any manipulation. And we are being honest, yes, but the error reporting is still quite underreported.
Right. So what I want to give emphasis on this, like what I request all the intensive care practitioners who are out here. So the most important benchmark what the JCA has laid actually for the international patient safety goals. So there are 6 international patient safety goals. I think they should go through it, and they have very clearly and elaborately actually written all the steps what are to be followed for the nursing care personals and what are to be followed for the doctors. I think that care bundle is there. I request all of them to go through.
Yeah, there are those 6 safety goals and each component of each. And again, I think majority will have, again, errors, medication errors and all coming into that. patient care again, elderly, the what do you say, the vulnerable patients and all those things. So it's very important. We in fact every year have this patient safety goal week where our NABH, I mean the quality department organizes games and what do you say, even memes and all over it. So I think, yeah, as you rightly said, that thing has everybody should know and follow. I don't know how much
How
it'll
about
happen
fire?
from the exam perspective, the patient safety goals, but yes, I think so sooner or later somebody will put that in the as an exam question also.
How about fire safety
Yeah,
goals
that's
and other
I think
drills that
those are now fire safety goals are being followed, because without that the hospital is not getting a license. So they are strictly followed. Even the older hospitals have to get it. Our hospital is making a complete lift. We are, it's a 20-bedded hospital. So for getting that fire safety license, they have built two huge lifts from the outside just for the fire safety norms. So that is quite, government is quite tough about it now.
Yeah. See, as far as these transcription errors or prescription errors or dispatching errors, which are very very common. So there has been a lot of emphasis on reducing their errors, but probably every hospital struggles to reduce these errors. Okay, I know manpower is also one more issue. Training is also another issue, and there are errors which are happening at every level, right from the doctor prescribing the medication to the sister indenting it, and then the dispatch from the pharmacy to everything. So whether it is JCI, I mean, we have been in JCI accredited institutions, so we have seen, in spite of having rigorous training programs and in spite of having rigorous, surveillance programs, with the training and everything, these errors have not been reduced. So what is your take on this? I mean, can you throw some light on this, because these are very essential and very
No,
important
no.
errors
So
that
again,
are
as I said, it
identified.
has to be self-motivated. So if
Yes, it has
suppose I am the
really matters.
in charge of my unit and I underplay some of the medication errors myself, then how do I expect others to do it? So unless you identify the errors, and as I said that the approach should be systemic improvements or system failure, not be treated as an individual failure. Whenever we detect errors and identify adverse events, the system has to be modified, not the individual. Because most of these medication errors, a newcomer must be doing it, suppose. So have we trained him adequately how to write the prescription? Or as I felt, when the NABH started, our verbal order thing stopped, or you cannot write it on the regular paper where we write our notes. So the even if suppose I see the patient as a consultant and write, okay, I write injection meropenem to give an 8 hourly. Now until somebody writes it on the drug sheet, the system may not follow it, even if it means the antibody going late to the patient. So I think these are some pitfalls of all these systems also, the JCI or the accreditation, NABH and all. So somehow we have to balance, strike a balance. But
So there
medication
are
errors, how is the reporting errors in medication errors in your hospital? Is it adequate, or you feel it's underreported?
see, there are two things. One is like reporting system still need to be improved. But the capturing of data, of course, it is most of the data, you can see the 90%, 99% compliance we have. But sometimes, sometimes there are a lot of, because of a lot of attritions nowadays, because of the
Yeah.
staff and other persons, sometimes the presentation of the data or sometimes the analysis of the data may not happen sometimes, many of the times. But fairly, as a JCI accredited hospitals, most of the things are at place and it's up to the mark. So there are one or two questions, like somebody has asked, what is your SMR in your hospital in Jaslok, and what is the CLAPSI rate?
So our CLAPSI rate is always following the international benchmark, even less than 1%. But SMR does go above 100. I mean, more than one, the ratio, more than 100. And that's what I said. This month itself, our SMR is more than 100. So as I told you, this case where the Apache score was only 14 or something, and still the patient died. So these things do happen, and yeah, at least it's an eye opener. Previously, we used to say, okay, हमारा mortality rate तो अच्छा है, लेकिन when we assess that the patient whose Apache score was less has died, then it opens your eyes. Why did this patient die? So when I was assessing this for this month, that patient of 14 Apache score died. So I've taken that case for the mortality morbidity meeting. So maybe something will throw up in that, what went wrong in that patient.
So being a quaternary or tertiary setups, we tend to get a lot of referred patients who are already
Yeah,
treated
yeah.
outside. So we get very sick group of patients. So it is very highly likely possible that quaternary or tertiary setups are likely to have
Yeah,
high
but Gunadha, that's
mortality.
what. No, we feel that they are bad, but when we suppose we go by only by the scoring system, clinically our judgment may be different. But if we go by only the scoring system, sometimes the scores are not actually high because that scoring system follows only a particular criteria. So if you see Apache 2, I don't know about Apache 4, a map of below 60, 60 to 70 more. But where have they mentioned NORAD? Suppose a patient is coming from an outside, as you rightly mentioned, he's coming on 5 ml of NORAD. We go 5 ml NORAD, the BP may and the map may be good. Then he's not, but he's in shock. We know that he's in shock. So there are these fallacies in this systems also.
So that is the reason most of the times now this SMR actually is going out of the box in many of the Western countries.
Yeah.
Because there are a lot of fallacies in collecting the data, a lot of fallacies in interpreting the data. And when your numbers of admissions are more, and if you are collecting a data which is less than the number of admission, sometimes you find, because the mortality remains same, your SMR automatically goes up, like the case you have highlighted.
Yeah.
And when sometimes in a sick patient, young patient, where actually the Apache scores are pretty low, but patient is actually clinically sick, you're looking at the initial days of illness, and if he or she dies, then that also you can find the falsely elevated SMR actually. So that is
honestly, if you see Apache, where does it see INR, where does it see liver enzyme? So it is not taking liver into account at all. I mean, of course, their liver cirrhosis is considered as a comorbidity, but you could have a well compensated liver cirrhosis and a non decompensated liver cirrhosis. For both, the Apache score will be different, but the Apache score has not included liver enzymes or INR or albumin.
right. And as you rightly told, like it is not only the one indicator which will gives you the absolute value for your hospital. It should the overall, the interpretation of many indicators which are interlinked, and that should be the benchmark for that particular hospital.
Interesting thing I read while preparing for this was, what they said, that the error rate was more. You would expect the error rates to be more when your ICU is busy. But interestingly, they found that the error rate was more when your ICU was less occupied.
Absolutely.
Okay, so one of the reasons, but they said that when your ICU was more occupied, you were too busy probably to report errors. Secondly, they found that the adverse events were more when your ICU was busy because you are probably, so that's how things work.
So
Still,
I have
probably
Do
this,
something. Yeah, sorry. Yeah,
probably this still, whatever indicators in ICU there are, we can use them to anticipate the things.
Yes.
Even if they have lots of fallacies, but still we can have lots
Of course. Yeah.
lots of anticipation,
So
and
if
we
you
can
are consistently having a CRBSA rate which is more than the benchmark, then you definitely, it's an indicator that something is going wrong. We need to see whether our processes are wrong, where we are going wrong.
I mean to say, we should not get biased with the score. We should always correlate with the clinical thing, and then we have to anticipate what is going on. This is Gunadha sir always tell us to anticipate the things what is going to happen, and then act accordingly. So that this point reminded me.
Yeah, that is individual. But suppose as an how do you outcomes कैसे, like how do you know what are your CRBSA rates? अभी उसमें until you do it over a periodical basis, you will not know how your, because we always feel
Yes, definitely.
Yeah.
And a very important point.
Persistent chasing will be needed to have that all the indicators. Even if anything is missing, we can correlate clinically, and we can always have those anticipation in our cards.
Yeah.
And the important point by Dr. Girish, like system thinking should start. It's the system which is problematic and not the individual. So whenever there is any problem, right, is rightly told by you also, we should try to improve the system and not to point out at a single individual. at that point of time.
Yeah.
So I have one question, Dr. Indranil. Probably, I mean, there is a lot of hue and cry pertaining to the antibiotic consumptions. Even the restricted antibiotics are being
Yeah.
consumed a lot, and there is justification being implemented or advocated probably. And then, we have antibiotic stewardship programs, antifungal
Yeah.
stewardship programs in place, and still, in spite of having these robust, surveillance programs and measures, we have not been able to reduce the antibiotic consumption. So, do you think any scoring system will help us, or any kind of? I know the system has to be evaluated well and thoroughly. It has to be revamped, and probably everyone has to be brought on page. The education of the consultant, the physician, or probably
One,
the
I think as far
clinician
as ICU
needs
is
to be
concerned,
justified.
closed ICU would help us for antibiotics.
Yeah. What do you think?
Open ICU, I don't think it is possible. And open ICU, it is possible only if the management supports you.
So even in closed ICU, the problems are the same. I mean,
I'll give
there
an
has
example.
been
When
in,
we started our antibiotic stewardship, and we had this form where if you use this, we made a form where this 10 drugs were used. That was long back, and then you have to give a justification. Like there was a column where it was empirical based on evidence and this thing as per the culture report. And then if you have given uh, not according to this, why you have used it, explanation. So and if the explanation, if the form was not filled within 24 hours, the pharmacy would withhold the drug. Okay. So there were many consultants who would fire the MD. Arey, how can you stop my patient not getting drug? My patient, my patient mar jayega, will you take the responsibility? Then obviously management is going to take a foot back, a step back. So
but what should be done for this? Because there has been indiscriminate usage of antibiotics, and we are already facing the antibiotic resistance issues, and we don't have any drug available. New antibiotics are also available, but in these situations, what should be the stance of a clinician, like you being an intensive care head, and then your
I
MD is
think
also,
I
being
see you both have also
interrogated
been
totally by the clinician.
you both also have been working in Apollo for a long time. So if senior people like us take a stand and take an effort, extra effort, and speak to the consultant and try and convince them, I think it will make a difference. Because if our juniors do it, maybe they will not listen. But probably if we pick up the phone and talk to them and reassure them that this is not required, maybe that's the way we can do it. Because all this stewardship form and everything, we've tried everything. It's difficult because then they feel like if there is an Afro consultant transplant patient transplant likha to then you get the license to give everything.
No, we have started this
Has the,
stewardship actually now
has
across.
the justification form been
And
has
who
the,
and what
have you
justification
got
you have given? Who is going to assess those forms? कि आपका
right?
justification बराबर है कि नहीं?
Yeah,
वहाँ पे
that is also
problem है.
very important. Those writing is also very important because the consultant is never available for writing the justification. And it is his poor RMO which is probably not trained enough to write the justification, and he's filling the form. And then don't get adequate data as well, I think, whether
Absolutely.
the antibiotic was justified or not. So probably somewhere or other, the senior clinicians only have to take a call on this filling justification forms. Then only probably will be able to reduce these issues.
So I think with no more questions, so we would like to end the session. So Swapnil,
Sir,
Dr.
there is one question.
Okay.
Yeah.
Should medications error written in file or separate? Because relative may sue. Any comment, sir?
Sorry.
Any
Should,
comment on it?
should medication error
Written in file or separate? Because relative may sue over the.
but medication error, who writes in the file? You don't write in the file.
Exactly.
We have a separate form online available by the quality team. We fill the medication error and then we send it across to the quality team, which does a RCA over it.
Yeah.
So this thing is probably not being disclosed to
What will
relative.
you write? What will you write in the folder? Medication error occurred? Obviously not. You will not write it in the folder.
Yeah.
So I think Swapnil, we can conclude the session. Swapnil?
Yes, sir. Sir, before concluding our session, I'll request all of our students to focus on nephrocritical care review course, which will be having hands-on sessions and online sessions for important lectures. And we are going to provide the nephrocritical care manual, which we are ourselves are going to prepare. Otherwise, it will be of 3-day course. First day will be of online, and 2 days will be hands-on. So it will be 20, 21st, and 22nd of next month. So all the details has been given in chat box. It's a website of 360criticalcare.com, and there they will have students can find all the brochures
2 days hands-on,
related
what do
to
you
it.
want to do? 2 days hands-on, what will be there? I mean, CRRT and everything, or
No, it's basically in the 2 days. The first half will be some lectures, and
okay,
the second half will be the machine learning, the
okay,
CRRT machines, lead and plasmapheresis, and hands-on for ultrasound guided venous access, the ultrasound, the renal ultrasound, and those kind of things, actually troubleshooting.
yeah.
So that is. I also
Priority on ECMO.
Yeah, so I'll also send you the details. So if you are available, please do join us. I'll be happy and send across all your students, because you are
Sure.
leading all academic program among the students.
Yeah, but we appreciate your academic program. A lot of my students, I mean, in fact, as I told you earlier, that we even tweak our program because our program was also on Saturday, on Thursday at the same timings. And many times we are taking our program because your topics are really interesting and good.
No, thanks.
Thank you very much, sir, for that.
Yeah, thanks, Dr. Zindan. Actually, it's a wonderful talk, and really thanks from our critical care department. And we'll like to have you here in the future also, many of our programs.
Sure.
So thank you. Thanks a lot.
Thank you. Thank you.
Thanks.
Thank you very much, sir, and thank you everyone who has attended all this thing. And I request all of students to take advantage. All these recorded videos will get on our YouTube channel, which is already placed in our chat box. Thank you very much once again.
Thank you. Thank you.
Thank you, Dr. Indrajit. Thank you. Bye bye. Good night.